achievement in member of NAMS Task Force on AI in Healthcare. He's a distinguished guest at G20 Consultant Meet at AIMS Rishikesh. He has also got a 5-star mentor award and top voice on LinkedIn in USA. So he's going to talk about from Udaipur. So welcome, Dr. Avneesh.
Yeah. Am I audible?
Yes, very clear.
Hi, Dr. Rakesh, and I hope my screen is visible.
Yes.
Screen is visible and it's moving, right? Okay.
Yes.
So, hello everyone. Good evening, and I am from the city of Udaipur, Rajasthan. And first of all, I would like to thank the organizers, especially Dr. Rakesh Srivastava, for being with me throughout planning this all this talk and everything, supporting me and giving feedback as well. And it's really great to be here, although I'm joining online because of some prior commitments. But I'm thankful to Dr. Rakesh for making all arrangements and allowing me to do so. This is about me, already introduced by him. So I'm a LinkedIn top voice and also part of many global panels on AI in healthcare. I work with a few organizations, and also if you guys, any one of you has been to this place, you will recognize that it's the Times Square, and I have been featured a few times for my educational efforts for medical professionals on AI in healthcare. So just so that you know that I am someone credible who can talk to you about AI. A few disclosures. Since I talk about AI, so I use AI a lot. So the first question which I like to answer whenever I'm talking to someone is why? Like I start all my talks with answering the question why. So why we are sitting here today having a CME on AI and talking about such advanced topics like agentic AI. So I think both of these pictures will be very much resonating with the physicians who are sitting in this room. So we can relate with both the administrative burden and the information deluge. The previous speaker before me, he was also talking about this exact dilemma that there's so much evidence coming out that it's very difficult. Like it's almost 13 years you need to make up with 1 year of new medical literature. So it's 1:13 ratio, which is quite unsustainable. And for every 1 hour of direct patient care, you are doing almost 2 hours of administrative tasks. This is, of course, from the Western world, but I think things are changing and they are reaching this same situation in India also, especially in corporate hospitals. So my topic, agentic AI, which is like something like a new clinical co-pilot, and this is going to redefine medical practice. So before this talk, even I was not too much delving deep into this topic. I was more focused on the traditional kind of AI, generative AI softwares which are coming out. But then I realized that AI agents is the next thing. And why I say this, because yesterday's AI tools, all these ChatGPT, Gemini, and even all those clinical tools, they're all static analytical tools. You either input an image or you input a database and you get a response from AI. That maybe it might be a classification response or a regression response. And that's it where AI stops as of now. And most of the people in this room, I guess, are very, very much well versed with this kind of AI. But now the world is moving towards clinical AI agents. And I'll show you in my talk that how these are different and what difference these are going to bring to the workflow, because they are, of course, dynamic, goal-oriented, and they work like a teammate. So from a tool, AI is now converting into a team partner. So this is the change that is happening. And not just based on your inputs, it is also now going to proactively partner with you in your workflows in times to come. So this is why we are discussing this topic. And if you see this diagram, this is like a 4-step process which these AI agents do. Perception, reasoning, action, and learning. So it's like a loop and it goes on continuously. So, healthcare is a lot of data, and many of the data points are now becoming digital. So multimodal data is being perceived by these agents. But the important thing which these agents do is the reasoning part, which is they use ML algorithms, and by ML we mean machine learning, and they do reasoning in the background, and then they take an action also sometimes autonomously. So you might have built an AI agent, and you might have set a workflow. You need not decide for the AI agent every time what to do, whether not to do. So it can take some steps on based on the workflow that it has been trained on. And of course, beyond this, it learns and improves. So it takes feedback, it improves, it adapts. So any AI system which has all these 4 components and it is doing this in a loop, that becomes kind of an agentic AI system. So basically, you're not doing a diagnosis based on an image or some kind of parameter, but you're automating entire workflows. This is where the magic happens. So just to wrap your heads around it, so traditional AI may be something like you have an AI model, you put an X-ray and it gives a single report. So this is kind of traditional AI and it stops here. But clinical AI agent would go 1 step or 2 steps further. It will flag the suspicious findings. It will auto route it to the concerned specialist. It will also give a real-time alert to the primary physician, and it will also put an update into the EHR so that you can focus on clinical decision-making and patient care. So that is why the topic is why it is enhancing or revolutionizing the decision-making process, because it will free up a lot of time and bandwidth for you. So this is in brief about such a complex topic, and in a small amount of time of 20 minutes, I have tried to make it as simple and as short as possible. But I know you might have to go through this again and again. But this is good enough for a primer on agentic AI and how it can revolutionize workflows. So let us see a few examples after this slide, but let us first see how it is different. Let us revise. So primary functionality of a traditional clinical AI, I told you, it takes a static data, it gives a report, it gives an output. But clinical agents work on an entire workflow. Clinical AI traditional is just like a tool, but a clinical AI agent is like your team partner to whom you can delegate some action. I told you the loop, the 4 steps, it goes on in the clinical AI agents, but traditional clinical AI doesn't have any such kind of a loop. Once you train it, you use it, then next time again you have to train it on new data. So it is not like an agent. And it is good enough for a single task like a narrow AI, but then if you are having multitask complex workflows, which we all understand as clinicians in medicine, nothing is so simple. So you will always need some kind of a clinical AI agent instead of a single AI tool. And this is where ROI comes out. So many people ask me, what is the ROI of AI? We have been having it for 2-3 years, but what is the actual ROI? So I believe the actual ROI of AI is logged into this agentic workflow systems, which if we are able to decipher, they can like through countless small efficiencies which they build into the workflow. I think that will be the real ROI. And these can be some of the things which can help to be improved, like reduce administrative load. And burnout is a big issue. Maybe that will come down. It will allow you more time with your patients, and it will enhance your decision making. So this is the ROI which is logged behind the doors of agentic AI. So now we'll see across specialties, just because I know we all are clinicians. There might be some people from general practice background, some from specialty. So I've tried to keep a few use cases. So this is the general traditional workflow which we follow in our clinics. A patient comes in with symptoms, they give us a history, we talk to them, and then after they leave, for 10-15 minutes, we are writing the note, or maybe in front of them, we are typing the note on the keyboard and not looking at them in the eyes, and we are doing all kind of paperwork. This is when in systems where EHRs, electronic medical records and electronic health records are quite prominent. I have worked for some time in Dubai, Middle East. So there, everything is electronic medical record. There's no pen and paper. So every medicine order also you have to put into the system. And unless you put an order, the patient will not get it. So all this work has to be completed manually for every patient, every time the patient is coming into your OPD. You can understand how much inefficiency it creates. But with an agent, now you can have an ambient voice agent, which is listening to the consultation, filtering everything which is important, converting it into a note, and then it is giving you the final output for you to just review and sign it off. So you can see how much time is saved, like more than 80% documentation time is saved per patient. And this will ultimately translate into what we are searching for as ROI from these kind of AI systems. So this is just one example of an agentic AI system. So it is not needing your input at every stage. it is only you might have to start the recording, or that also may be some kind of a cue word like maybe hello Mr. So and so, and that can trigger the kind of the AI system, and it starts recording the conversation, and it will give you a finished note, and all the steps in between it will figure out on itself, and it might be having more agents behind the scene. Maybe there's some kind of an agent which is searching for the latest evidence in the background. That might also be there. So that I will show you as we go on. But this is some kind of an example just to show you how workflow changes from traditional to with an AI agent. Similarly, for a cardiologist, I know if some of you are cardiologists, you must be knowing, you must be giving Holter monitoring to many of your patients. And one of my friends, he had atrial fibrillation, but he got Holter monitoring. He kept it for not just 48 hours, he kept it in fact for 1 week, and still there was nothing in the Holter monitor. And there were symptoms, there were some ECGs before that got that kind of a recording, but the Holter monitoring failed to capture it because of the limitations, because maybe that time he didn't get an episode, and you will only intervene when there is a symptomatic event or a sign on that kind of a monitoring. But what about if you have a 24/7 kind of a monitoring system, which is something like an AI agent, which gets triggered? It has a lot of kind of evidence and all those telemonitoring kind of things in the background which are built. And this is not science fiction. There are some companies already working on it, like AliveCore and PM Cardio, where the patient wears a wearable device not just for 48 hours or 7 days, but it continuously analyzes their ECG. It might be a smartwatch. And as the AI agent detects atrial fibrillation instantly, it doesn't need an input from the patient or the doctor that, okay, what it should do next. So it will directly alert the physician and the patient, and this will enable proactive care. So this is how, again, workflow changes for cardiology. And similarly, there are so many other specialties. I just kept a few because I knew these specialties might be more in the audience. So this is similarly for an ENT and workflow, and you will be seeing a product which will be launched today, which will be showing you how agentic workflow can be applied to ENT. So this is just kind of a summary diagram. Maybe you can take a picture of it to go through it in your free time. So dermatology, psychiatry, all image-based branches, and even the branches where patient is used to having a conversation with the chatbot or the LLM. Those are the specialities which can benefit with the AI agentic workflow. And it has a lot of value impact which is logged, but you have to actually decipher the workflow and then build an AI agent around that workflow to get the full benefit. So I know this talk should not go too much technical because we are not a technical audience, but let me just explain to you in a simple way, because many of you, I guess, are very much well aware about the large language models like ChatGPT, Gemini. Many of you must be using. So just try to look at this picture and keep that in the background. So suppose I put ChatGPT here as an agent. So a prompt template is something like you have a set of prompts which you have already built. So every time you're not writing from scratch, you have a template which is built in instructions, which sometimes in ChatGPT you can give as a custom instruction. And then there's a LLM in the background. So ChatGPT is not a LLM for those people who are confused. The LLM behind it is GPT-5. So that is the LLM, and that is built into that ChatGPT user interface, and that is what you see. So ChatGPT, in fact, is an agent. It's not a LLM. This is something which I realized when I was studying for this, and I talked to a few people. So nowadays, these tools like ChatGPT, Gemini, Grok, all these are AI agents because they have all these components. These are like the architecture of an agent. It has to have a prompt template, a LLM, a memory kind of a feature where it can remember what it is talking, and tools. By tools, we mean some kind of a database which it can go back, like a patient record, which it can go and access, and it can give you an answer, or maybe some kind of evidence-based RAG system where it can go and take out the relevant study and give it to you, and you are the user who is prompting and getting response. So just to simplify this architecture, we can also look at it like this. This is a more simpler depiction for us. So these are the basic components of an AI agent and how it works. And you can maybe take an analogy of a single player in an orchestra. So every single player in an orchestra can be one agent. You can take this example and you will see how it connects in the later slides. So this is a single architecture I was talking about, and this can convert into a multi-agent architecture. Nowadays, we have the technology to build multiple agents and then club them together. And there's a tool for it, which we'll be seeing in the next slide. But this is how a multi-agent architecture looks. Every agent is talking to other agent, and the main agent is in conversation with the user. So this becomes something like this. Now, there are multiple players in the orchestra, but still the picture is not complete. So why it is not complete, I will tell you. But before that, just understand how it applies to medical. So in medical, suppose you have a multi-agent system, there might be one agent who is taking the patient, gathering patient details like patient demographics, patient history. All these you don't need to take. Already the agent which is there in built, it can already prompt the user to put all these details, and it can gather it and convert it into a summary. It can synthesize the data, or it can pass it on to another agent which can do a data synthesis, and then an agent can do differential diagnosis, and finally an agent can suggest treatment plan. So multiple agents working together on different tasks as a specialty, and then they work like a clinical team, and you are the one who is getting the benefit of this multidisciplinary clinical team which is working for you as a multi-agent system. So this is what is agentic AI in a simple way. We are moving beyond simple chatbots and into multi-agent systems now. So I told you there is one missing thing, which is in an orchestra, if you have people playing and they all play by their own rules, you will never get a good music. So you need some kind of a master conductor. There are many tools out there. There are now many more platforms, but the most famous one, and which Dr. Rakesh also mentioned to me when we were preparing, is LangGraph. So this is something like you can see in the picture. So it is like multiple agents, and then it provides a platform for every agent to connect to each other. So basically it's an orchestration framework, just like an orchestra, and it defines the workflow, which agent for which task, for which time it should trigger. This everything is built into this kind of orchestration framework. And these are the nodes and edges. So the agents which you see, the robots, they are the nodes, and the edges are the lines which are connecting them. So you can see they are all, basically they are showing the flow of execution. So it is like a flow chart, but a technical flow chart. So with that you can understand. So also the important feature is it has a shared memory also. So one agent knows what another agent is doing and what the entire system is having the memory of. So whenever I trigger a new agent, it will be having that entire context. I don't need to tell it from scratch that this is a patient of 55 years with chest pain and coming at the middle of night. It already knows. So it will start working from that point. So that is the power of LangGraph actually, and it transforms completely into a dynamic end-to-end system. So this is just to give you a teaser, just to show you how things are built. I don't want you to become an engineer, but for you to be able to talk to engineers, I think this kind of knowledge is very important. So there are many other tools. Don't think this is the only tool, but this is what it does. So now your orchestra becomes complete, and you have everything. You have players, you have multiple diverse kind of agents, and you have some kind of an orchestration framework. So this is how it is built. And this is just an example. It's open source. It is available on GitHub. It is built by someone else, not built by me, but it's available out there for you to check how an agent is built and how an agentic workflow is done. So this is basically a AI kind of a multi-agent system, which is helping a clinician in CDSS as well as in generating reports. CDSS we mean clinical decision support. So a user will input at the top, and it might be speech, text, or image. Depending on that, it will take the image, and then the chatbot or the agent, this is the agent, the green one, this will get triggered, and then it will decide which agent to give the task to. So it will either give it to a medical agent decision-making tool or a LLM-powered conversation agent. So these two agents are different agents with different specialization. And this medical agent decision tool or agent is built for recognizing the abnormality in the image or the skin lesion, anything, and then it verifies with the human, and then it passes it on to the main orchestrator again, the assistant chatbot. You can see this diagram, and then this then goes to generate a report. And even in generating a report, it is taking the RAG. By RAG, we mean it is taking evidence from whatever literature is there. It is collecting everything, and then it is using to generate the output. So this is just a simple example. I'll just end my talk after this. So this is just to show you how an agentic workflow is built and how much the workflow is very important to decipher to build an agent. If you are not sure about your workflow, you will never be able to build a good AI agent. This is a key message which I want to give you. And of course, the ethics, you have to also see the hallucinations. So you must have seen in the previous diagram, there's a human in the loop validation for the clinical diagnosis. So already, always you have to build these kind of guardrails into your agentic system. You cannot make everything autonomous. Then again, the data sets which you use, they have to be bias free, they have to be from diverse sources. And as my previous speaker mentioned, the personal health information security is also important. Removing all the patient identifiers like name, phone number, and all those things are very important. And finally, the question after seeing this talk, many of you will have that, okay, then are we out of business? Is medicine a gone game for humans? But then I would like to say you it's not, because you see there are many things. Yesterday I was in a CME, a derma CME, and the doctors were talking and they were saying that we prescribe a particular antibiotic, so this ointment. But it is in Rajasthan, if you know, every medicine has to go from the hospital. It is given free to the patient. So sometimes there is a different brand, sometimes there is a different molecule, or sometimes a molecule is getting expired sooner. So the doctors start writing the molecule which is expiring sooner. But this kind of information is not fed anywhere. It is only tacit information. It is only the people who are inside the department, they know it, and they know these kind of things that happen. And this is for the benefit, because we don't want to waste any medicines. We want to flush it out fast so that we can get a new stock, not to harm the patient, but to prevent wastage. But these kind of things are not recorded. So always human AI is going to be a partnership where AI will be helping you with data analysis and support, but you have to be the person who judges and who gives the empathy part. So don't worry, there's only the way of working is changing, but the human AI partnership will definitely be needed in times to come. So key takeaways, we are moving from passive to proactive kind of a systems with AI agents. We are definitely now going to see more better solutions for clinicians, because till now we are all frustrated with AI. It is only solving one problem, one particular problem, and only in the laboratory. But once it gets into an agentic AI workflow, it will provide real solutions for clinicians and across specialties, from cardiology to dermatology to ENT. So we saw a lot of examples. And multi-agent systems are definitely going to revolutionize, because single agent system is so powerful, but then if you build an entire orchestra around it, so you can automate an entire workflow, and you can maybe do task of 50 people by using a single person. So for people who are running standalone clinics, I think this is a great thing for them. And future is human plus machine. So I'll just take a few more minutes to just give you clarity on how to get involved. I know I've crossed my time of 20 minutes, so I asked Dr. Rakesh for a few extra minutes to just let you know. He has prepared a very nice document which he shared with me, and he will share with you. So you have to start small. Don't get overwhelmed. Today's talks might go above the head for many people, but then understand that even I was at this stage 5 years back. You have to start small, be in a community, take advantage of this kind of workshops and literacy events. I think this is not the first workshop which will happen in Lucknow. Many more events will be planned, and always try to participate. And once you get a bit of skill, start collaborating. You must be seeing in the VoxmedAI team, there's a lot of diverse people, and many are educated AI literate clinicians, and along with them, there is a technical team behind them. So AI is a team sport, and you always have to collaborate in the end. But before that, you have to choose your role. You have to be a consumer, or you want to be a developer yourself, or you want to be somewhere in between. Depending on that, you have to go deeper into these kind of technical concepts, ethical concepts, validation issues, and appraisal issues. You have to dive deeper. You have to learn more and more depending on your role which you want to take. So you can take some photos of the next few slides. There are a lot of QR codes. You can go and you can read these papers, and these will help you in understanding what I'm talking about. So you can take photos of these QR code slides. And this is another paper which we wrote, which is Navigating AI, a quick start guide for medical professionals, where you can set goals, you can identify resources, and then you can measure your success. And we also give a checklist of how to get started with AI. So you can take a photo of this slide as well. Then we also did a podcast on the same article. So if you are not a reading kind of a person, if you want to watch, you can go and scan to access this talk, and you'll have a lot of questions answered, how to get started with AI in healthcare and build something like VoxmedAI and Dr. Rakesh Srivastava and team. So this is somewhere you start. And Lastly, I want to introduce you to Doctors AI, which Dr. Rakesh mentioned. This is an organization which came about as a WhatsApp community. We started with 5 or 6 members, and now we are more than 2,000 members on the WhatsApp community. This is the QR code link to our website. You can go and explore more. So just a briefer, we want to promote AI literacy among medical professionals. We want to foster AI entrepreneurship, and we want to spearhead AI integration into medical practices and research. We are a new organization. Doctors AI is a very new organization, just incorporated in March this year as a not-for-profit company. And this is how we plan to go. We are working a lot on AI education, and AI research projects are coming up now for validation. And we also look in future towards AI collaboration. This is the advisory board, and I'm the advisory board chair, and we have a team of 12 doctors at present who are all AI literate physicians and who are trying to build kind of a ecosystem for this kind of activities. We do a lot of weekly activities, free weekly activities like update hours, monthly webinars, journal clubs. We also conduct a lot of workshops. We also did a student workshop last year. We also do AI primers in medical colleges. So if you are from a medical college and you want to do a primer in your college, just like this CME, you can drop an email to Doctors AI, and we can take it forward from there. This is a podcast. You can keep taking photos. I'm going fast because I want to end it. The next speaker is waiting. This QR code will take you to our podcast. And great speakers come every month and talk to us about AI. Many of them are doctors and entrepreneurs. This is a book which Doctors AI has written for physicians who are getting started with AI. This is a first edition. Second edition will come out this year. So this is another thing which you can explore. This is a certificate course on AI in medicine. So we are having the second cohort now, and next cohort will start in January. So this is also available on our website. So if you are interested, you can drop an email to register your interest for the next batch. It's a 3-month, 42 hours live weekend kind of an activity where you learn every weekend for 2 hours, and you do a capstone project also. So you can join here. You can join the WhatsApp group. You can join the LinkedIn community. And if you are really serious, just like Dr. Rakesh Srivastava, you can become a member of the college. But before this, let me just tell you that 300 plus people have joined, and it's still getting structured. It's something which is new. We have just started with lifetime membership at a very nominal price. And we want to structure it with all of these members, and more AI projects will be coming in for validation, and it will be floated out. And these ICM members will also get discounted rate for our summits, and they will also be able to participate in ICM activities as speakers. So this is something, and this was our last summit. It was totally virtual. It was on 2 days, and we had 100 plus faculties and 1,000 plus attendees. And this year we are, so these were the organizations we collaborated with. This year we are going live in Bangalore. So it is on 15th and 16th November. Deadline for increasing the slab of registration is 15 September. So if you are really interested, you can register before 15 September at reduced prices. And if you are an ICM member, you will get a further reduced price. So this is something which you should come and look towards because it's a 2-day complete physical conference. And if you are having an AI product or you're an AI entrepreneur, you can also participate as a knowledge partner with us. With this, I just end my slide, and you can slides, and you can connect with me. You can take a photo of this last slide, and this is the QR code to my connections. And I'm happy to answer questions on email, or even if you can ask Dr. Rakesh to forward the questions to me, I'll be happy to answer. With this, I'll end and hand it back to Dr. Rakesh. I hope I have not overshot my time of 25 minutes. Thank you so much.
Great, Dr. Avneesh.
Yeah, thank you.
Really an eye-opener from perception AI to generative AI, then agentic AI, and now finally we are into, next time we'll have a physical AI.
Yeah,
So,
definitely. We'll have a physical
so
event.
we will have a robotic that Jensen Huang, what he said about the evolution of from agentic AI to physical AI. So next time we'll have a robotic here, and we'll have a talk. Robots are talking to each other.
Definitely. My best wishes to your entire team, and for the launch of the product, and for the next talks which are coming up. I'll be definitely watching them as a speaker. Thank you so much.
See you in Bangalore.
Sure. See you in Bangalore. Bye.
So next speaker is my co-founder, Dr. Shashidhar. And he's a person who motivated me, but My motivation came in AI when I saw the video of Demis Hassabis and what he prepared for the AlphaGo uh, when he prepared a software uh, that is Go game, and you must see that inspiring uh, what you call documentary, almost 2.5 hours, on how the Go game, he broke the Go game, and then Demis is now this year Nobel Prize winner. So he was a AI, and he will go through the product, what this TM classifier, which we have worked for almost more than a year. So we are after this we are coming with two more products this year. Hopefully one laryngeal image classifier. Another one is the breast sound classifier for pediatric and pediatric patients. So नहीं ये नहीं है, यही है ना AI नहीं तुम्हारा यही है हाँ या ठीक क्या है उसमें
Okay, a very good evening. All of you must be a bit tired now, rested, but this is the most interesting part. How is it going to benefit you? What are you going to do with the AI when you're in your clinic? And how is it going to save time for you? That is the most important thing. Because we can talk endlessly about AI, what it can do. But what it has done for me is the experience which I want to share. Is it really the best tool? And I'll give you a very honest opinion. And it's a mixed review about it. So to start with, I work as a ENT head at Artemis Hospital, and this is where it is going. So, we used to go to NML library to study and all. Now getting the knowledge is so easy. And we are coming at this place where we can create the knowledge exponentially. You can pull out knowledge which is already there in the stores, and this is where the graph goes much faster. And that's why people are putting money into it. Like every year, the CAGR is like 30 to 46%, depending on what model of AI and what sector it is being used. But people are literally pouring money into it, and these are the projections. So if this would have been one of the shares, I mean, AI would have been a share called AI. You should have bought it and been a billionaire in next 20 years. But you don't know how to use it in the clinical practice. And that's where doctors are supposed to do, how we can save time in this. So I'm just putting here what happens with the data. If a patient is admitted here, he has a whole journey which is to be completed. Uh, I can you put this down, please? Okay, so he has a problem, then he has to go to an ICU. Somebody makes a diagnosis after doing certain tests. Then a consult is given to an ENT surgeon. ENT surgeon identifies the problem. He says, okay, this is what I'm going to do. I'm going to do a balloon dilatation. And then he also wants other specialists to meet. On a single day, we are getting data in these forms in the most simplistic way. And these are the data which are already there once in a while, like you do an echo, uh, and these are the data which are there very sparingly. Sometimes the notes are written, sometimes the notes are only cut and paste of what it is in the morning. Small changes is there. So there is no way on earth a system can be built in a hospital where you can collect data in all these parameters through all these days in the hospital. 12 days, 35 parameters is impossible to collect even in the best hospitals in the world. So whenever you are getting a data, it is lot of it is confabulated right from the human hand. I mean, you give a thesis to a student and you'll understand where it is going. first 5 patients done and the rest 15 is. So same thing will happen when you are making an AI system based on the data which we already have. So it cannot be relied on to a large extent. But if you are curating and training your own data, there is a chance you will succeed. So when you see in AI, in laryngology or any other specialty, it can only do two things. It can classify and it can predict, and it can do it pretty well. I'm just giving you the examples. So when you do it on a paper with a, what model you're using to classify or predict, and what are the parameters you're using, and it is in the science stage. But when you make it a device, it is called the practice stage. Like Olympus system has, one of the NBIs can be taken up for the AI and everything. So in practice, you're doing it. And the last part is actually the delivery part. So from going from science where we can do it to the practice where we are doing it and to the delivery where everybody is adopting it is a 8 to 12 years of journey in medical science, even with the AI. So when you understand this problem, then things become more clear that, the science stage has been solved largely here. The bigger challenges are here in the practice and the delivery part. And that is where the tools come. What are the tools you can use? What are the tools you may not use because it is not helping you much? So just to start with, this is what we call YOLO, you only look once, which was used for traffic monitoring, where, different cars are going and the camera can quickly identify it. It can be done on a webcam. Okay. And same thing can be used in the larynx. Like different objects in the larynx move, vocal cords, arytenoids, we can track them. And same technology is used in drones to track things. Same technology can be used to see where is the bolus of the barium, like you're giving something to feed, how is it transitioning? We can track it down from the mouth, from the throat, from into the windpipe or into the stomach, where exactly is going. And we can get, images and we can get data from it, which can say, okay, this is an auto-generated report that you're reading something and this is how it is done. And this is being done, and this is in a software, but still stuck in the science stage. That system getting into the delivery phase where you are getting into a computer and to the doctor and using that system has still not happened. But on the paper, it was there 4 years back. So there are 10,000 things which are still in the science stage. It's up to us to bring it into the delivery or the practice stage. So we can listen to voice and sound and predict n number of diseases like Parkinson's, laryngeal cancers. We can see dysarthrias, neurological conditions. We can pick up pediatric conditions based on the voice problems. And there's so many publications on those. So we wanted to put it in the practice state. So we made a classifier here. Can somebody give the audio? Where a child is making a sound, strider sound. Can somebody give me audio? Yeah, this is a breathing difficulty. And the AI can tell you exactly is it subglottic stenosis or trachea, where exactly is the problem. So this was a case of subglottic stenosis where a video is uploaded and you can diagnose. Same we can do it for this child who's crying because of breathing problem. It picks up and it can tell the diagnosis. Now, but we have trained the data only in the children. But when we use the adult data, the computer gives a different output here. It says adenoids and tonsils, but it was a vocal cord paralysis. So you will have exceptions when you're using these systems. But this Strider classifier, which we developed, had 110 samples, and we still have 40 to 50 more in the pipeline. And it has an accuracy of 80%. So, but as we keep on training it, we will get better at it. The processing time has reduced to less than a minute. It can be deployed on a website or an app. And we are still in the testing phase, but we should be able to get it on
60 samples.
within a year's time.
I think Dr. BP Singh is here. So he must be seeing a lot of patients of OSA day and every day. And this will be a great tool for you to, an adult patient, to see the site of obstruction, whether it's a multi-level, whether it's a nose, nasopharynx.
Where there's an asthma, breathing difficulty, somebody has a breathing difficulty, and you put a cell phone on next to it and record the voice, the AI would be able to tell, okay, this is where the likely problem you need to see an ENT or a physician.
Not all V's are asthma.
So there are many things like tracheomalacia, bronchomalacia, which present like a wheeze. So we are trying to develop that distinction that by the sound, because many times the patient refuse for bronchoscopy, even pediatric included. So that is why this was actually came to my mind almost 2.5, 3 years back, when Professor K.P. Kushwaha from Gorakhpur referred me a patient saying that I am referring this patient to palatal cord palsy. Have you seen that patient? Have you done the bronchoscopy? My experience was that palatal cord palsy. So I thought, okay.
So same thing we can do with.
So then this thing has came to my mind that sound we can do it. So results are not, there's confusion is there. So
yeah. So I think we will get their higher numbers. 90 to 95 should not be very difficult with more data coming in. The other one, Dr. Rakesh also is working on is his NBI and laryngeal classifier, where we got a accuracy about 97%, where you put an image of the larynx taken with a video laryngoscope, and it can give the diagnosis. And the time here is like 0.3 seconds. It does images much faster than the sound, but
very fast.
But we are going to get this launched much faster than the sound and the voice trainers. So to start with the tools, I'm just putting one story here. 9-year-old fainted for 5 months. Every single day, this child used to faint. Like he would get up and then he'll do something like this and faint. And seen admitted in AIMS, worked up at different places. And we took it as a challenge, and we used certain AI tools, and this is what I'm going to share. To diagnose this in a record time, it was me and another doctor with me, Dr. Trisha, who were working on this case. And what really happened here was we put the whole data of the child, the episodes and everything, and asked several LLMs the questions. What is the probability of the diagnosis which you had? And then it kind of gave us a chart where it was came out to be completely unexpected, a type of migraine. And all we had to do is treat it with a migraine medication. And after 5 months, the child was completely relieved. He was treated for narcolepsy, epilepsy, pseudo seizures, malingering, even went to a psychiatrist. So that's the power of AI, where you can actually remove your own bias and actually get the numbers to know that what is the probability and what is the weightage these symptoms carry in the whole diagnostic picture. So Indian Express thought it was a good idea and they published it. We're grateful to them. So like I said, we can have a prediction and we can have a classification. And the last part is the recommendation. So when you want to use a tool, you need, or develop a tool, you want to know where are the brackets it's falling. Are you using it for prediction? Ear discharge, ear problem, what is the best ear surgery for it? Because there are 5-6 surgeries which can be done, and each surgeon will have his own way of doing it. But what does the evidence say? Recommendation is a much complex thing. That child with that problem, with that, uh, drug history and that allergies and so many other comorbidities, how will you treat it? What Dr. Vibhu was saying. So recommendations or clinical resource systems needs lot of predictions from lot of ends and then to consolidate into a meaningful thing. So we are not there at the recommendation part presently in our daily usage, but obviously this can be developed. So 5 tools, ChatGPT Plus version. I would just say Perplexity is now given free to all Airtel users. So get the Pro version. I'm still paying $200 for it. So get the Perplexity Pro version. Consensus AI, Scribe AI, Scholar AI. They're all single tool of going and reading multiple articles and bringing to you what these articles say and giving you a consensus. My favorite is Consensus AI. I'll tell you why. Gemini advanced because you can have APIs with it, you can do a multi-modal agents work with it, and you can actually make your own chatbot with it. Uh, so that's a good thing. Our associate Dr. Sumedha Rungta is very fond of making the chatbots. So I'm just giving you, case usage here. Uh, I am usually swamped with lot of queries from international patients here, and it comes like a CT report, no history, nothing. And all you need to do is like make a GPT which is just tailored to take an X-ray or take a ultrasound report or a CT report and just upload it, and it will go search your rate list of the hospital and then give the diagnosis, give the treatment, give the complications, advantage, and also give your coordinator's number, your website, and also write about it. And that used to be a lot of it, very, I just wrote, uploaded, give the possible treatment, and it starts off, based on the provider, it's a cholesteatoma, you can do these surgeries, tympanoplasty. Oh, wait a minute, it also has a sinus problem also. So, we can do a sinus surgery for him also. But because we are doing 2 surgeries, it will tell you, I'll give you a discount also. So, so it does all the work which you would be generally doing as a, your coordinator or 2 people will be doing in this. So that's the power of AI. And it takes 10 to 15 minutes to make a GPT of your own. No prior experience of AI or even coding or anything is required. All you need to do what it should do and give it data, it will do it. Second problem is insurance queries. I mean, this child had failed 5 times. We were writing. It was a mucormycosis. They were denying it, our, we'll only give 1.2 lakhs, this and that. And it went back and forth. So we asked it to write a very strong letter. And, it wrote like a lawyer. I'm writing to formulate denial of claim list this in prejudice. Key issues are this unjustified delay in processing, life threatening nature of the condition, and immediate demands from a doctor that if you don't do the demands, next step will be, we'll escalate it on social media, on star obligations, this will pursue legal action, this and that, everything, and signs at my behalf, sent there. Within 10 minutes, we got the approval. So, why would you waste your energy and your time trying to fight with an insurance company? Your energy should go on your patient. You should fight the patient's disease. So these are the big time consumers. So I'm just giving you examples. Then always like patient is leaving, he'll come back. Can I have orange juice? Yes, you can have. Can I have mango also? Yes, you can have. And even after he leaves, comes back in 10 minutes, again he has something to ask. So then I made a GPT for prescription explainer. So you just take a picture of this and all of you can do it. It's a very simple point. So it will tell you what are the do's and don'ts. Okay, and it will pick it up from really good sites like Mayo, WebMD, and everything. And then it will also check for the drug interactions, what these drugs have common side effects, like ecosprin, Crestor, these side effects. And it can also tell you, what two drugs can interact with together, then tell you the warning signs which the patient needs, general dietary advice and physical recommendation. So anyone who comes back 2 times, we take a picture, PDF in less than 20 seconds, tailor to him, sent him on the email. He's so happy. I mean, this saves lot of your time, and patient gets a complete like, ये doctor जानता था मेरे को क्या चाहिए करके. So you can't deny how useful this. The other patients are like multiple files, seeing 4 doctors, and he asks you for a problem which you don't know is your problem or their problem, but you're trying to write something. And so those prescriptions needs to be cross-checked against each other, and this will do it very nicely. So same thing, they'll check do's and don'ts and everything, but go in every prescription and list all the drugs in one go together, because patient will come, मेरे को क्या खरीदना है? So it will tell him क्या खरीदना है, and then warning signs, drug interactions. Like I didn't know levoflox and pantoprazole interacted. But it does tell you, and then it tells you general dietary advice, supplements, what needs to be taken, nasal care, and all those things. So this kind of completes you, because your intention is to give a best possible care to a patient. Having just the chat GPT, your own GPT tailored to your needs, just completes the consultation. Then obviously similar, like, can I give this medicine? And you have the whole history, everything, take pictures of the discharge summary. But this was like a patient who was congenital myasthenia gravis, and it saved me from giving him antihistamines. Like I would give it because he has a cold, as a normal doctor would, but then it would just tell me, okay, this is gonna, it will worsen the myasthenia gravis, stop. So they actually have a life-saving utility when you're using it in the daily practice. Or this is the worst. Imagine 8:30 you're leaving the clinic, a patient with vertigo drops in, and that can go an hour trying to solve his vertigo history. So what we made is like a checklist. The nurse outside will tick, 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 write 3 things about the symptoms. And all I have to do is take a picture and put it in the vertigo classifier. So it will list the name, everything, spinning balance, onset, and it will tell nurse forgot, not ticked. Okay. So then symptoms, it will go through it everywhere. Medication history, everything it will write down, because the nurse will spend 10 minutes outside, do the basic test of walking around, checking the eyes and everything. And it will tell the vertigo severity. And if it's a serious red flag signs which you have put it will tell you that, this patient may have a red flag. But the best thing is it gives the probability of differential diagnosis based on what you have put in the history form. And that's the beauty of it. It saves you time. Those ones where you have to actually work up and somebody has to apply your brain, you still have to do it. But, somebody giving you a nice summary like this, you're much smarter and much efficient to do it. And then you can go dig in and ask more questions to the patient rather than just getting the preliminary information. So this part usually is done by the nurse sitting outside. Consensus, I'll just, tell you that, if you give yes or no question, is Botox useful in muscle tension dysphagia? It will pull out all the papers, rate the papers according to the evidence, how good is the publication, and then it will give you a consensus. In the end, it will say, yes, 64% paper said, possibly 9 said, 18 mix said, no, 9 said. And you can play the game any way you want to. You can choose the things which you want to focus on. Because if you are to do the same thing on PubMed, you'll be lost. You'll have 40 publications. You have to individually go through it. So a lot of your questions, yes or no, milk is good in a child who has allergy. Answer, everybody will give a different answer. So when you put it in the consensus, you know what are the best papers which have been done on this. You know the worst paper would say it should not be given. Your job becomes much, much more easier. So this is again the same point when we are talking about agentic AI, we are talking about so much autonomous thing. This was a beautiful study which said, as a doctor, 80% of your decisions are done without any publication knowledge. You know, patient number 3 is very hungry and shouting everything, and he's scheduled to be operated at 2 o'clock. You would skipping and operate him second rather than operate him in third because he's the noisemaker. There is no AI which will teach you that. This is your years of experience which has taught you. So, as a doctor, the 80% decisions which you are making is actually not given in publications, not given in journals. It's your own way of dealing people and its own way of dealing the patients, how they are brought to you. So, only 3% of the decisions which you see are actually based on the published data. So, in this study, they had 1188 decisions which were made as a doctor, right from, what to give in the food and everything throughout the day. And then they kind of saw that, AI wasn't really helpful. So you're still going to do a lot of your things because that has really saved you and helped you over the years. But things which are scut work, which are consuming your time, that you can really use tools to shorten it. So one of the tools we use is Perplexity Labs because it does amazing result. Like here, the question is, Coblator, is it good for laryngotracheal stenosis, limitations and everything? And I wanted to put it in a publication or this. It goes so deep into it. It has searched 92 sources, website, journals, everywhere. And it gives you the information, everything. It gives you the papers in which stenosis were there, in which Coblator was able to cure. And it makes your own charts. In laryngo, cold steel was used 32% of papers. CO2 laser was in 60, coblation was in 40. So that consolidation, which is done by Perplexity Lab, is amazing. And it tells you the temperature and everything. So you get so much of data and all concised, which you can consume immediately. So if you had to use one LLM or the agent, what Dr. Khare was saying right now, I would say it's Perplexity because you can access any of the engines, LLM engines like Grok, Claude, ChatGPT, everything through a Perplexity machine and gives you references. And that's what we always look for it. So we did this experiment, and these are the hallucination rates of different engines, LLM. And this is going to change every 3 months or 6 months because they are improving very well in reducing the hallucinations as you use it. So whenever okay, I'll skip this part, which is the development phase of a software. But first step is actually when you're getting used into a digital space, you have to you have to choose an EMR because whatever you're going to create or use, you need a digital way of doing it. These are the top AI based or EMRs, which is basically electronic medical record, which you can use. And I've tested each one of them. My favorite is obviously DocOn, but I have shifted recently to Care and I'm not able to completely find this. But this is the market share, who wins and who loses. And if you look at this, each one has its own market, their ratings. I'm having a double voice, please. What are the AI features and everything? So you need to start using a medical EMR. And the benchmark is when you write with a prescription, you take anywhere between 20 seconds to 45 seconds to write your prescription. If you are able to do that on a EMR in the same or maybe marginally higher time, adopt it. If you're not able to do it, no wonder, no matter how many AI features or how many, advantage they are trying to sell you, it is useless to you, because when 40 patients are waiting outside or 20 patients are waiting outside, you can't be typing all the time, or your transcriber can't be typing all this. So when you put that as a test, I mean, DocOn wins, HealthPlex wins, EKK wins, and they do it by something called templates. And instead of typing it, you can actually tap on the iPad and it just goes in a zip. These are the two favorites, and you should test on your own to kind of get into any of those things. But absolutely important for you to get EMR in your routine practice. Even if you're in a government hospital, it would be helpful, because 5 years, 10 years from now, you will look at the data and you'll say, I can create something out of it. And that's the beauty of it. So first step is to get into EMR. Second is start using Notebook LM. It's a Google's free service. Everybody can use it. What it does, it's called a RAG, another way of saying a LLM, which only is working with the data which you have given it. So when you put some PDFs into it and you can ask questions on it, so it really helps you, because what it can do is you can put all the patient record of a single patient research article in one place and ask, is the treatment going all right? It will read the records, it will read the guidelines and tell you, there is something more you can do it. Amazing. Because it teaches you while it is doing you. So when you use Notebook LM, you will realize that you're actually learning much more. It can do a summarization. You put all the records, you can say, summarize the discharge summary for me, write 15 patients who can have a similar summary. It can just generate, fake patient records for you for, testing your residents, like a quiz. It can give you evidence-based insights. It can give patient handouts. And this I found it really good, because you can ask it to give in Hindi, Marathi, Gujarati, any language you want it to. You give the guidelines for Meniere's disease or any of the stroke or any protocol, and ask it, this patient has a understanding of 5th class or 7th class, make a Hindi or a Gujarati handout for do's and don'ts and what he needs to do when he should come for follow-up based on the treatment which I've put it. It will just do it seemingly well. Research publication, it's amazing. It can just write your article in 5 minutes. Just put all the 20 reference articles and ask it to write a review article. It will do it. Then you need sometimes a voice transcription service, which is basically when you're talking to a patient, everything is getting automatically recorded. I don't know if it's legal or not, but and then it just puts into the EMR. So these are the best. I've tested Ogneto. This is like amazing software to use Ogneto. EKK has integrated in it, so you get a EMR and your voice in this, but still it doesn't pass my time that I need to give my prescription in a minute or less. None of the voice transcripts will actually pass that yet. So you're still better off using the older ones.
So problem with this, all the voice apps, because the vernacular is different, the dialects is different, and sometime in our patient comes with their own medical terminology. So there is nothing like that. So we are researching on it. So I had a discussion with other colleagues from Lucknow University that because there's a app, the project by Ministry of Electronics and IT. So they have developed Bhashini, that is, so that we can use it. But still there are local dialects are there. जैसे अभी यहाँ आता है परी जाता क्या तो चफरा हो गया. There is no term like chafra. So there are medical local terminology is there for medical illnesses. भनभना रहा है कान, सर भनभना रहा है. There is no description in that Hindi about that disease. So that thing we have to include into.
Yes, I think as what Dr. Rakesh says, multilinguality is a problem. So most of these will work very good with Hindi and English translation. Regional languages, Tamil, Telugu, and Kannada are really well tuned off, which I've tested. But when you have a very local language, I don't know, but it always gives you the opportunity to correct it. So even if the AMR is writing something wrong, it's going to, you can still correct it. So 95% accuracy, it will go 5%, you have to correct it. But I use it, Heidi Health, or even the voice recorder of a Google phone while I'm doing teleconsults. Like somebody is on a video consult with you. So I keep the phone on and I record the conversation with him for about 15 minutes. Okay, this is the complaint in this. And the Google voice recorder will dramatically give a very beautiful summary. The patient has come asked these questions and the doctor has advised this. And when you put that as a summary, as a one page and send it off, it becomes a very billable thing. I've had international patients where we could charge 5K on a video consult because we were giving the summary of the 15 minutes conversation which we had. But it was only on just hello, hi, and talking and telling them. That's very difficult to kind of make it a billable thing.
Heidi is very good. One should use it because I'm using it for my operating records.
Operating records.
Yeah. So that we do it operating at the time of operation, we start recording it and immediately we send it to the EMO.
So free to use is Ogneto, and Heidi. The free version is there.
Yeah, free version is, so you can use it.
Ogneto has OT notes inscribed into it. So you can just tell it, patient name, doctor name, and mastectomy surgery. It will write the OT notes for you and give it to you straight away. Very, very easy to use. Yeah, sure.
These are fantastic examples. And it's very amazing to see these tools in the hands of a patient and being put to use. I realized in a number of examples you're talking about patient data being captured into the example and maybe sent, shipped somewhere into the cloud. Has that ever, in your experience, been a concern that either the hospital administration or the patients are voiced? And how do you see the staging as the regulatory landscape, especially the DPDP Act and things like this?
Yeah, I mean, that's a beautiful question. So make sure when you're uploading something, you're de-identifying the patient. The first thing when you do it, when you de-identify the patient, it's not a problem to put it on the cloud or getting some analysis done on this because it's the anonymity is maintained, the patient-doctor confidentiality is maintained. So even if you have to this is for the demo purposes, most of the times the apps which you are making, the first step is to de-identify the patient, and you're pretty okay with it. Any particular question you wanted to ask?
Picture of the data that you got, that becomes isn't that a little challenging to
Yes, but we may have to make some start because in India still the gray area, the HIPAA or compliance, we are not obliged. Legally, we are not in a soup with as if we are breaking the law. But yes, if the patient comes to know about it, he can have a discussion. But him coming to know about it is a very remote possibility because the chat GPT is not going to go and tell him that, we have this. But yeah, that concern still has to be solved. So that's why you need to have your own framework. And when you say you need to have your own framework, you need to implement the AI at your own hospital level so that everybody can use it and not breaking any law. But when you're in a clinic or you're testing or using these tools, you're okay. Yeah, I mean, I will not say keep just do it blatantly. Just make sure you're de-identifying the patient. Whatever it is coming is like without a patient name and age or GNID, you're okay. Most of the times you're okay. Also, pick up a course. And my journey was like catapulted because I could do an advanced certification in AI in healthcare from IIC Bangalore. Spent an year, 8 hours every Saturday, Sunday for a whole year, but it was completely worth it. I want to conclude it with one thing called a broken leg problem. A broken leg problem in AI is said, you can most likely predict when a guy and a girl are going to go on a date on a Saturday for a movie with having a questionnaire and 10 inputs in every way thing. But on the Friday night, if the boy broke his leg due to something, and that questionnaire or your AI model did not have that knowledge, all prediction will go wrong in a sec. And this is what happens in medicine. We have so many broken leg issues, right? Because the patient will not tell us, the resident will not put it, or some problem from your side you misunderstood or something, or suddenly something happened, and the predictions will all go wrong. So the reliance on the AI systems needs to be very, very careful. So FDA has not put it anywhere that this software should be implemented. Agentic, there is no chance, because uh, one mistake will amplify into a loop which you can't even stop it. Somebody gave a wrong information and the whole thing will blow out. So to corrupt or to create a problem in a computer, to really mess it up, you need AI. I can tell you for that.
Take a break. Just take a break.
Yeah.
Uh,
I think this is the conclusion.
Yeah.
Then you're the walk-in. Human mind is the biggest master. Use AI as a servant, not as a master. Don't just pick up your phone and start doing it for everything. Keep human in the loop and test them and imbibe them in what is helping you and what is not. Thank you.
So I request Dr. Sandeep Kapoor sir to give a memento to our guest speaker, Dr. Vibhu Agarwal. Dr. Vibhu, please.
Thank you.
No, this is and Dr. BP Singh sir to give a memento to Dr. Shashi. We are the host, but he has come all the way from Delhi, so I requested him to.
Thank you. Thank you.
आपके वैसे में भी आए थे. Thank you, sir. So we'll just have a walkthrough through the product. What is tympanic membrane classifier? That will take five minutes. Dr. Shashi, please.
So this is the staff of VoxmedAI. I'm Dr. Shashidhar, Dr. Rakesh, and our CTO is Dr. Giri Tatuvati. We have a resident, Dr. Sumedha. She does a lot of her work, so we just named her.
Dr. Shrey is also here.
Dr. Shrey is also there. Shrey Dodera.
He is.
Hi.
He has done a validation study.
Okay, Dr. Shrey Dodera has been just imbibed in the presentation.
Validation from District Hospital Sitapur. So the product has gone to the. So we have collected a few samples from other hospitals also. So he will highlight the results.
So the website is Otosensai, which is otosensai.online, and it is online actually. So you can go ahead and test it. It's a software which can diagnose the ear condition. Just one second. In an instant, and it's a very reliable diagnosis. So what we need to do is basically, it was a challenge. How do you get a picture of the ear? So there used to be an endoscope which you're using as an ENT, but now on the Amazon and several, there are ear cleaning cameras, and they're as cheap as 750. What Dr. Rakesh today was saying, it performs better than a 8,000 camera which we bought 2 years back. So And that's become very cheap and universally available. Any pediatrician, A&M, or even a patient can just buy it, and he can put it in the ear and take a picture of the eardrum and get an image. Once you have the image, you can actually put it for the AI for analysis. And this is what I'm going to run through. What are the different things it can do? So it's a simple, there's no login, log out yet. I'm just putting the images which we took. It's an image of a wax in the ear. It will ask that, we are doing it for educational research purposes. Absolutely not. And it gives a diagnosis in a second. Wax, eardrum classifier. And then you can have other conditions like congestion here, what is called as acute otitis media, and same. And this is a real-time video which has been recorded. Because it has fluid in it, it comes with a different other diagnosis and it gives you the confidence. I'm saying otitis media with effusion, but my confidence is low because there are other things which are also happening. And if I give something like this is ear grommet, which is covered in a lot of wax and everything, it is looking like a foreign body. It will tell it's a foreign body in this, but it will say my confidence is low. And this ability to give the confidence and reliability takes a lot of training into it and a lot of coding to kind of come to that measures. But things which it understands beautifully, it will tell with a very high level of confidence. Like that image which we put was a eardrum patch, and it kind of puts it highest that there are calcium deposits in the eardrum. Like this is a hole in the eardrum, which I'm putting it, which is called CSOM. And I ask it to analyze this image. And these are very low resolution, poor quality images. Let me tell you that. The ones which we get in clinic are very high resolution ones. So it has been trained on all the models. But for the demo purposes, I'm putting the worst images, which are very difficult for people to understand. So there's a hole here, tiny hole here. And if I WhatsApp images, and if I just put it for analysis, it just says it's a CSOM because it has a hole in it. And it has a medium confidence. And it also gives less likely conditions and other things. So we can build on it. Do you want to see an ENT specialist for this? You can, it can educate the people what needs to be done and everything. But we know that, in India, people will play with it. They will also put images which are not here at all and ask, what will your AI do? So we were already prepared for it. So we had to train it in non-ear images also. So I'm actually putting here an image of the nose and asking it, what is this? Instead of imagining things, it will tell it is not an ear. Image does not show ear structure. This is much more difficult to build than the normal structure because there are a billion things which are not ears. Like this is a bad fungal infection. And it will tell you with very high confidence that it's a fungal ear infection. So the deployment would be with A&Ms, general people, like this is some fluid in the eardrum with bubbles. And when you put it for the analysis, it just says with a high confidence it's otitis media with effusion. So anything which is classical, it will hit like a nail. Anything which is confusing, it will give you the directions. Like this is a mosquito in the ear. Like that is the diagnosis. And it will tell you, okay, something's in the ear, which is not a wax, which is not something else. It's a foreign body in the ear. And that's what we say. So we took about 80,000 images to train it. And that was painstakingly collected by both of us for last 14 years, 15 years. And our CTO is very imaginative. He's a PhD, so Dr. Giridhar He keeps coming up with newer features every now and then. And this wouldn't have been possible without his hard work, where the deployment is actually practical. As you see it, upload it, like this is a grommet in the ear, it will just tell you straight away that it's a grommet and very high confidence. So now this is thrown to the public to use it, and it will be, we are hoping that it will be a boon to a lot of pediatricians, general practitioners, and other things. All they have to do is, somebody is complaining of ear pain, just prescribing ear drops, they can actually put it in the AI and get the answer, which would be much more accurate than a resident level ENT surgeon. And we should be able to get the approvals and patents very soon to kind of use it in
We
an
have
app.
applied for the patent and it is published also. So shortly we'll get the patent. And SMD also we have applied for SMD class B. So that is in process. So, but on a desktop, the web version, we have launched it, but not as an app formation. So, still validation, we are still doing it with support from other